So we're going to talk today specifically about neck and back pain. And we're going to have a brief review of the physiological effects of laser therapy as it will relate to treating those types of conditions. A couple of research papers that you should be aware of about neck and back pain. Treating the cervical spine with laser therapy and treating the lumbar spine with laser therapy, including some case studies, which hopefully you'll find interesting. And we'll go from there. So let me just do a quick check again to make sure that you can see my screen. Everyone says you can see my screen. Excellent. Okay, so many of you have seen this picture already, but a quick review so we understand how laser therapy may help the healing of both acute and chronic degenerative and injuries of the spine. So first of all, we should realize that there is a component of light therapy that will help with increasing blood supply long term. So this would be angiogenesis and neovascularization. So in tissues that are hypertonic, the muscles are tight, adhesions, injuries where blood flow might be compromised, prolonged exposure to LLLT will help improve blood flow. Another important aspect is collagen production. Of course, that has to do with repair of tissues, and the importance of that I don't need to explain any further, I don't think. Another really important aspect of light therapy is its ability to help regenerate muscle tissue that's been torn. So for example, in whiplash cases, those types of injury scenarios, so it can improve both the strength and the actual healing of muscle tissue. And we all know the importance of light therapy's effect on inflammation with respect to its role on circulating white blood cells and the ability to modulate pro and anti-inflammatory mediators. And of course, if there's issues with nerves, cartilage, or bone, we know that the mechanism on the mitochondria, along with other physiological aspects of cellular function, are increased, thereby improving the ability of light therapy to heal tissue. This paper I always bring up, and it's important that everyone out there knows about this paper because it's from The Lancet, which of course is one of the premier highest impact factor journals out there for physicians. And Roberta Chell did a paper on a meta-analysis paper on neck pain. And the most important thing that I think that was concluded was that she said that laser therapy reduces pain both immediately, but also for a period of up to 22 weeks after the last treatment in patients with chronic neck pain. This is really important because we all know that acute patients tend to get better fairly quickly for the most part. However, chronic pain sufferers, they're more of an issue. And we know that laser therapy can last, the effects of it can last a significant period of time. So we need to be able to understand that component to this type of therapy and its importance. This paper was specifically on chronic low back pain, and they looked at, it was a randomized controlled trial with 3 groups. Those 3 groups either receiving laser therapy and exercises, or placebo laser therapy and exercises, along with a placebo group. The parameters, the laser therapy group, then laser plus exercise, and placebo laser plus exercise. So there was no actual placebo group. That you can't really do that in these types of cases. As you can see, the wavelengths used, lambda is a short form for wavelength. It's 810 nanometers, so infrared, 50 milliwatts, continuous wave. And I want you to notice this. They treated them twice a week for 6 weeks. So again, to be effective with laser therapy, you minimally have to treat patients twice a week. We prefer 3 times a week, but twice is oftentimes adequate as well. Treatment time was quite long, 20 minutes. And again, this is sort of relates more to what we do here with BioFlex laser therapy with longer treatment times to induce bloodborne effects, systemic effects, as well as localized effects. So here are the results. Essentially, you're looking at week 0 and then week 12, comparing laser therapy plus exercise, and then the placebo group. And you can see the VAS from 7.3 down to 4.4 for the laser group, the 6.2 starting point with laser and exercise down to a 2.4. So clearly that indicates that if you add laser therapy with exercise, then of course that's even more effective than just exercise on its own. I'm sure everyone out there would agree that by combining laser therapy with other forms of therapy, including exercises, your patient will improve much faster. Same thing with disability index as well too. All showed greater improvements when combining laser therapy with exercise. So it's a nice paper to show that type of synergistic effect of laser therapy and exercises. So let's talk now a bit about neck pain. About neck pain. So in order to be successful with laser therapy and any type of therapy, you have to be able to target the tissue that's injured. So if you're treating neuropathies or fibromyalgia or something like post-herpetic neuralgia, you want to target the posterior ramus of the spinal nerve as much as you can with laser therapy. If the issue are facet joints, then of course you want to treat over the articular pillars, both from anterior and posterior aspects if possible in your patient. If there's muscle tenderness, you want to palpate and treat those both local and distal trigger points or myofascial points. Headaches, you want to focus more on the occipital region and the nuchal line, the most common etiology of headaches. If there's issues with the brachial plexus, then you of course want to make sure you're treating the pathway of the brachial plexus. If there's autonomic symptoms, one thing you might not be aware of is treating the stellate ganglion, and we'll talk a bit about that as well too. So as you can see, I know these are all things you're familiar with, but sometimes if a patient's not getting better, you may want to go back and say, okay, what is the exact target for our laser therapy, and am I directing the light at the appropriate tissue for long enough to achieve the desired effect? So if we're looking at the dorsal ramus, a bit of anatomy, you know that the superficial target is going to be, at each dermatomal level, and you can actually have a nerve blocking effect if you aim the laser probe around the medial branch of the dorsal ramus to in fact inhibit nerve conduction flow and therefore block pain. This is something Roberta Chow does a lot, and you can certainly do that with the LDI 200 probe by applying it over the dorsal ramus for 10-15 seconds at one time, depending on the musculature and the soft tissues in the way, and you can achieve this type of nerve blocking effect as well. So recall that the articular branches of the facet joints and the periosteum of the vertebral arch, where it's located, okay? Remember that this supplies visceral motor, somatic motor, and sensory information to and from the skin and the deep muscles of the neck. So that's kind of what you're targeting when you're trying to treat these branches around the facet joints. They tend to be very sensitive and oftentimes a big part of the etiology of neck pain. So neck pain specifically due to facet joints, this is a very common problem with as many as 36 to 67% of patients with neck pain. That reference is from Bogduk. He's a well-known researcher into spinal pain, taken from a Spine journal in 1988. So recall that facet joints are diarthrotiosynovial joints. They have a fibrous capsule, and what's really important is they're richly innervated by both proprioceptive and nociceptive fibers. So a lot of pain emanates from the facet joint and the capsule, and you need to make sure that you're directing especially the laser probe over the articular pillar and the facet joints to try to help with this type of pain if that's part of the etiology. So again, a review of anatomy. Those facet joints lie about 2.5 centimeters lateral to the midline in the back of the neck. And the most common facet joints to be involved in arthritis tend to be mid-cervical spine in the C5 and C6 region. Don't forget that you want to apply some pressure with the laser probe. This enhances penetration by pushing blood out of the way and getting the target laser light directly to the facet joint. So as much as the patient can tolerate, gently push in the probe to displace the tissue overlying the tissue that you're trying to treat. Remember to hold the probe at 90 degrees, not at an angle. If the probe is at an angle, sometimes actually some of that light won't make complete contact with the skin. It might get some reflection off. So the correct application is to maintain a 90-degree orientation of the laser probe over the tissue to ensure as much light to be absorbed as you can. So we typically, for example, when we're treating the neck, we're going to start superiorly and centrally and work her way inferiorly and peripherally up and down the neck and across the shoulders and mid-scapular areas as the etiology indicates. Okay, so make sure you do it in a pattern that is reproducible and you cover all the areas that you need to cover. What you shouldn't be doing is sort of one point, say at the upper part of the neck and then going somewhere else, and then sometimes forgetting what you've treated and not treating the area completely. So you want to treat at the insertions of the occipital and nuchal line, at both origins and insertions of muscles, around the shoulder girdle if they're contributing to pain, over the articular pillars of the facet joints. They typically lie on the average person 3 to 5 centimeters deep. So these are all the structures that you want to target with generalized neck pain. Don't forget about trigger points. And don't forget about treating the sternocleidomastoid. That's also really important. And another anatomical structure that you may want to treat, depending on the signs and symptoms, is a stellate ganglion. So be aware, remember, if you're treating the anterior neck, of the thyroid gland itself overlying the thyroid cartilage. So you can easily treat the SCM, just make sure you don't have light directly over the thyroid cartilage itself. The stellate ganglion is the main switching station for the sympathetic nervous system in the neck, and basically it helps control blood flow and some degree of pain in the face, neck, arm, and hand, as well as the upper chest. It's oftentimes implicated in conditions like reflex sympathetic dystrophy, Raynaud's syndrome, patients that have excessive sweating, and this is due to the autonomic system. Sometimes unexplained headaches and pain in the face can be caused by stellate ganglion issue, herpes zoster, and I already have excessive sweating. So these are all symptoms or conditions that you might want to look at treating the stellate ganglion if in fact the patient has these types of problems. Recall that stellate ganglion lies in the anterior portion of the neck, just superior to the clavicle, just off the midline. It lies deep to the SCM and the scaleni, so you need to roughly, put the probe in that region and hold it for at least 10 seconds to initiate light to get into the stellate ganglion itself. The brachial plexus, again, an anatomy review for everyone out there. So if you're treating a brachial plexus lesion, make sure you're treating along the path of the brachial plexus. Okay, it's not just good enough to treat around the neck and the upper portion of the shoulder. You also want to treat the path of the brachial plexus as it makes its way down towards the shoulder. Okay, so again, in cases of cervical radiculopathy, you want to make sure you're treating the appropriate nerves and the pathway of the nerves along the brachial plexus as well. Okay, so hopefully that was clear to everyone and a bit of a review, and hopefully you gained a bit of insight into treating those conditions with laser therapy. Lumbar spine case studies. Essentially our approach is to always identify and treat the source of pain and the cause of that pain. You want to, of course, do a thorough physical examination. Diagnostic testing may be required. You want to heal the origin of the pain. You just don't want to basically, put a Band-Aid on the problem. You really want to get to the root source, okay? Once the patient's feeling better, then they can start to do some exercises and these other things as well, too, to help them speed up their recovery. We typically start treating immediately and oftentimes on consecutive days, 3 or 4 in a row. Then we tend to go to 3 times a week every second day during the next week or two, ultimately going 2 times a week. It might be for 2 weeks or 3 weeks or 4 weeks, depending on how the patient's progressing, and eventually down to once a week or a release of care if they're 100% pain-free. The first case is a disc herniation. A 39-year-old land developer. He has presented with acute low back pain, basically just, started when he bent over to tie his shoelaces. Had similar episodes in the past. However, this one is a lot more severe. Previous MRI had him showing bulging discs at L4, L5, and L5S1. He was quite in bad shape upon presentation to us. He had to ambulate with a cane. Very difficult finding any position that was comfortable for him. There was scoliosis due to muscle spasm right up and down the thoracic, mid to lower thoracic, down the lumbar spine. Everywhere was acute. to palpate, and you can see straight leg raising was reduced. Neurological examination was really challenging at that point because the patient wasn't able to tolerate it. We did an MRI. It showed a small central disc bulge, L3, L4, with mild thecal sac effacement. At L4, L5, again, another disc bulge centrally. The bulge extended into the right lateral recess and quite a bit posteriorly. So obviously, it would make sense that it was compressing the nerve roots at that level. So this is how we approach treatment. On the left is the sort of prescription that Dr. Khan wanted for this patient, including laser therapy. Along the way with massage, stretching, strengthening, and swimming was recommended over a period of 4 to 6 weeks. The first week we saw him consecutive days for 4 days. Second week we broke that up into every other day. And then into the third and fourth week, every other day for the third week, and then just twice a week into the fourth week. So that was how we approached treatment for this patient. The protocols were such that we added an extra placement at the thoracic region, the mid to lower thoracic region. So this was an extra placement that you may not be used to be doing. Red was set at continuous wave. Infrared, we added another extra placement, in the thoracic region, as opposed to just the L4, L5 region. Started at 50-70, and again, you can see the overall duration of time. We did 75 milliwatts of LDI 200 infrared. That equates to about 42% of the LDI 200 probe. And we did 100% LDR 100 laser probe for 10 minutes. Again, that 100 is really important for treating the nociceptors and the pain at the surface of the skin and underlying cutaneous tissue. I'm going to take a break right now and just mention, if you have any questions for me, write them out, send them off to me, and I'll do my best to answer them at the end of the webinar. Okay, so by treatment number 3, we increased the intensity, that is the dosage of infrared, to 90% duty cycle, and we increased the LDI 200 probe to 100% from 42%. And those are the changes at treatment number 3. By treatment number 5, we started to pulse the red light of the red array. Okay, and the reason for that is accommodation that the patient is starting to perceive, especially of the red light. We find that pulsing that red light after a few sessions is helpful for improved response by the superficial tissues. By treatment 7, you can see we then went up to 250-90, so we start to pulse the infrared light a little bit more. And this patient, obviously with this severity of a condition, he was treated over quite a long time frame. By the 23rd treatment, you can see we start to really ramp up the frequency of light of the red, keeping the infrared still at about 250-90. So remember that as we increase the frequency, we're not increasing the dosage, we're increasing the pulsations of light. The dosaging of the light from about the 7th treatment onwards was about the same. It was a frequency that was really rapidly increasing over a period of time. So the clinical outcome after 27 treatments, the patient was essentially significantly improved, probably 90% plus. He was able to resume his activities of daily living. He was back to work and his regular activities full time. We did recommend maintenance laser therapy, 1 treatment a week for another 8 weeks to just have a bit of ongoing stimulation. And by the 35th treatment, he was discharged. That seems like a lot of treatment, but remember, we're talking about a disc herniations that are quite severe, which, you know, is not, you can't relate that to a mild muscle tear or a bit of facet irritation. So bear in mind that it's a lot of treatments, but we were able to achieve really good success over a relatively short time frame. It would have been over a period of months for completion of the treatment plan. Second case is advanced degenerative disc disease of the lumbar spine. This is an elderly patient, again, low back pain in a chronic mode, and of late it had become relatively acute, restricting his walking and other activities to a significant degree. He had a history of a laminectomy about 1.5 years prior to visiting the clinic. It did help, but he was still having some chronic pain issues. Had some cardiac issues, was taking some ibuprofen for pain, but as you can see, was also on occasion taking more powerful analgesics like OxyContin and codeine. Examination results, essentially his leg length was equal, some limitations of his straight leg raise, issues with decreased ranges of motion of his lumbar spine, a bit of a rotation and scoliosis at his TL junction, probably due to a bit of spasming. Also some tenderness overlying the thoracic spine and lumbar spine, a fair amount of kyphosis due to the aging process. He also had some hip issues as well too, probably again some arthritic degenerative conditions going on there as well. He did have an MRI. You can see the results here. I won't go over any specific things here, but if you look overall, there's a fair amount of degenerative disc disease right from the upper lumbar spine down to the lower lumbar spine that was having foraminal encroachment that was causing a lot of his issues. So as opposed to disc, we're dealing with more compression due to the degenerative process of the spine. So again, the prescription, this patient wasn't as acute as the first patient. Laser therapy was prescribed, but again, instead of 4 treatments in a row, Dr. Khan prescribed 3 treatments in a row. We initiated some stretching exercises, a bit of massage a little bit earlier as well too, a bit more aggressive with that because of the degenerative nature of his condition. And similarly, by week 3, we were able to get him to twice a week into the week 3 and week 4. So let's take a comparison look of this type of treatment compared to the that first case scenario. You can see the placements are more standard, overlying the thoracic lumbar junction and L4, L5, S1 junction bilaterally over the SI joints and the exiting nerve roots. Okay, continuous wave, and you can see the infrared 50-70, the extra placement overlying the L4, L5, S1 region. Similarly, the LDI 200 was set at 42%, 100 for the 100% for the red. Not quite as much time required for the laser probe, 8 minutes as opposed to 10 minutes for that initial patient. Okay, so overall you can see we didn't require as much time, as many placements, or as much intensity for this patient compared to the initial patient. On April 20th, you can see we increased the dosage a little bit from 70 to 80. We increased the dosaging of the laser probe as well. And then by treatment number 6, we started to pulse the continuous, or the light from the red from continuous to 190. Okay. And by the 12th treatment, we were pulsing the infrared at 250. The dosage is staying at 90% for red and infrared. Okay. And by the 14th treatment, over 2 months, the patient was essentially 80% overall improvement. Wasn't requiring any specific medications for their pain, able to resume ADLs, exercises, and swimming. And again, we recommended a maintenance laser therapy, ongoing to prevent further degeneration or slow it down. I wouldn't necessarily say prevent, and help with continuous ongoing tissue regeneration. So those 2 examples I wanted to show how we would approach a really acute hot disc compared to, not quite as acute, a bit more chronic, degenerative types of scenario, and the time frames typically involved. So hopefully that is helpful for most people. There's just a few minutes left, about 5 minutes left. I'm going to just take a look to see if I have any questions here as I pull them out. So let me just take a look here. Okay, well, I don't see any questions right now. If you do have any questions, feel free to email me at david@bioflexlaser.com. Okay, the next webinar will be on, I believe, tinnitus and TMJ, as I recall. That's next month, and then I'm going to be putting up the list of the remainder of the summer and early fall webinars over the next week or two, so check back then as well too. Don't forget that we have a training seminar here in Toronto coming up in July. We also have a date in San Francisco, I believe, as well, August 5th and 6th, if anyone is listening out that way or would like a trip to San Fran and get a training in as well. We'll be out there in early August. Okay, thanks for listening, everyone, and we'll see you next month.